My honor, it's a double honor. One, that we had international celebrity attending our instruction course, sir. And today, we are privileged to have you. I invite you here, sir, to deliver your keynote address.
Well, good afternoon, everybody, and thank you very much, Dr. Haldipurkar, other members of the panel. I have already learned a lot more than I can teach today, so thank you very much. And a good amount of my talk and some of the salient points have already been covered and demonstrated in the videos you have seen. And just to re-emphasize some of those, in iatrogenic iris trauma causes and consequences. So let's start at the beginning. What makes the iris vulnerable to trauma? The iris is very thin right at the root, at the periphery here. So that's where it tears very easily, and we have seen that in this picture shown before of iridodialysis, which happens with iris root tears. It is also a very vascular structure, and it bleeds quite easily, and you can get a lot of bleeding from the iris root. You can get a bleeding from the pupillary margin, where often there are little tufts of vessels. You can see them on the slit lamp and anticipate this problem, but often they are missed. They are fairly common to see, and they can be as part of the normal structure or as part of some disease process in the past, as we see over here in this iris angiogram. And even the fact that if you have a perforation with the iris over there, you can get vessels from the iris growing into the cornea in a centrifugal direction. So it shows you how vascular the iris is. The iris structure is made up of mesodome and the pigment epithelium. The pigment epithelium is very easily disturbed, and as it comes out and with your manipulations, you get this transilluminant areas of the iris because of the trauma of surgery. You get pigment dispersion with pigment collecting on the lens, which can cause glare and halos on the iris and also in the angle, causing glaucoma. The lens gives good support to the iris. If the lens is not there, the iris flaps around, and a floppy iris like that can be easily sucked into instruments or prolapse from the anterior chamber. That makes it a little more vulnerable. And then when you do anything to the iris, as we have seen, even a dilating device, stretching, cutting, or as in this case, stitching, you get prostaglandin release. Prostaglandins are the common cause or the culprit for cystoid macular edema. So when you have manipulated the iris, think about the possibility of cystoid and give a prophylactic course of steroids to these patients, increase the topical dose that you may normally give, or consider a short course of oral steroids. Now, what are the risk factors for iris complications? We've seen a small pupil, shallow anterior chamber, floppy iris, patients on tamsulosin, and a large wound, not well-constructed wound, high irrigation pressure, and positive pressure due to choroidal vasodilation. If you suddenly lower the aqueous, release the aqueous, and there is sudden collapse of the anterior chamber, sudden hypotonia, you get choroidal vasodilation, and that can cause the positive pressure on the back of the eye. Now, when you see something like this, and we've seen this repeatedly today, the iris coming out, it is primarily due to increased pressure in the eye and due to a poorly constructed wound. The last thing you want to do is use some kind of a hook instrument to push it back in. And I will illustrate that in this video kindly lent to me by Sadir Hanush, a corneal surgeon, and he's doing DMEC, phaco-DMEC. So the lens is put in, everything is okay. The DMEC scroll is injected into the eye, and as he's taking it out, because of he's releasing the pressure, but this prolapses out. Now, as you try to push it in, like you do with the iris, you try to push it in, the hook will catch on the iris root will have a small tear, you get bleeding, and there's blood all over in the anterior chamber. So you've caused iris trauma and made life very difficult. In this case, the blood was sucked out, all that, and a little extra time, and the operation was successful. But instead of trying to push it back, release the pressure in the eye and tap it back with a blunt instrument. Just tap over here on the cornea. If the pressure is not high, the iris will go back in. Now, the other risk factors, of course, vitreous loss, and if vitreous loss is not properly managed and there is vitreous in the wound, then the whole iris gets pulled to that side. The proximity of all the instruments you're using to the iris makes it more a high risk of damage, and as you can see over here, the patient's visual outcome will be poor because the edge of the optic is visible in the pupillary area. And then head movements. Now, this happens rarely, but when it happens, it can be a problem. This routine cataract operation going, and suddenly, it's not the camera that is shaking, the patient has made a movement. Now, this was one of our residents who was recording this. Fortunately, he managed it very well. But you can see the iris trauma and even the corneal trauma. And see, when the iris is damaged, that floppy iris wants to come straight into your suction device. So you have to bear that in mind, put extra viscoelastic while you're taking the cortex out and try and avoid that. But here, the outcome was successful, but notice the little posterior corneal trauma as well as the iris trauma caused by the sudden head movements. Now, these are, of course, well-described risk factors, and we've seen many of these previous iris disease, small pupil, stuck pupil, and when you try to enlarge the pupil by whatever means, you're going to cause iris damage. Even while releasing synechia, you're causing some iris damage. Here is a patient where we had a cornea graft with cataract and a very fibrous capsule, and we are using the stretching. I use the Hirschberg hooks to stretch the pupil, and that is causing tears, minute tears, or at least rips in the pupillar sphincter muscle, and that is a kind of trauma which I was alluding to earlier, will release a lot of prostaglandin and will cause problems later on if, in some patients with cystoid macular edema. And all of these are causes or risk factors for iris trauma, and the way in which the iris is damaged by the prolapse, aspirated into the instruments. So many times you've seen chaffing and the phaco probe catching the iris and taking bits away, iris root stairs, etc. Now, this was one example again where the lens had opacified, and the opacified lens is being explanted from the eye, and you can see the video over here, what happens. All these maneuvers in the eye to try to take out a calcified lens, often you have to cut the lens and take it out, but as you're explanting it from the bag and trying to bring it into the anterior, on the anterior capsule or anterior to the iris, you can see it digs into the iris roots and causes tears and a lot of bleeding. So that what is to be avoided or kept to the minimum to avoid damage. Here again, the iris has been caught in the lens, and clearly you've got problems with the lens being in the anterior chamber and causing corneal as well as iris problems. These are some examples of iatrogenic trauma, and you can see the iris can be quite distorted by even malpositioned, malfixated lens, subluxated iris claw lenses, etc. And this is an old Sputnik lens that is dislocated and causing trauma to the iris. So what happens when you get iris trauma and the pupil distortion? You get all these symptoms: glares, halos, dysphotopsia, uniocular diplopia, quality of vision is poor, cosmetically it may not be good for the patient, and you eventually have a very unhappy patient. So how do we deal with these traumas? You have to look at these 5 considerations. First is the optical, the shape, size, location of the pupil. Is that okay, and how can you get that back right? And at the same time, visualization of the retina. The question was raised, will it be good enough to see the retina if you want to in the future? Structural, if you're dealing with healthy iris tissue and dealing with atrophic iris tissue, the strategy to manipulate that will be different, because atrophic iris tissue is not as elastic, doesn't stretch, and when you try to approximate, it will tear or the sutures will cheese wire through it, causing more damage rather than fixing the problem. And then functional, does it address the patient's visual symptoms, which are of course the biggest concern for the patient? Cosmetic, obviously you want to give the patient a good outcome, because some of them are more bothered by the cosmetic appearance rather than by the vision, and you will see patients who want it to look better rather than to see better. So that is their wish, and you have to bear that in mind. And expectational, so you have to inform the patient of all the pros and cons of what might get worse when you're trying to make it better, complications, etc., and that the cosmetic result may not be guaranteed. So you can do these measures preoperatively by preventing iris damage. So mainly pharmacological, and we've heard that stop all miotic alpha, be aware of patients on alpha blockers, pseudoexfoliation, some of them on the non-steroidal anti-inflammatory drugs. We stop those because of the fear of melts, etc., and give them mydriatics or preoperative steroids if they've got iris inflammation in the past. Herpetic eye disease, herpetic zoster, and simplex patients will have a lot of iris transillumination, and when you see that, then it's worthwhile covering them with antivirals preoperatively and carrying them postoperatively with oral acyclovir or ganciclovir. Intraoperatively, we've seen all the maneuvers people have done, and they're all just listed over here. We've heard them, we've seen good examples how to prevent iris trauma. And again, to show you this little video here where we are doing corneal graft with a lens extraction implant, the same patient with an atrophic. So releasing synechiae are going to cause peripheral iris tears or holes, which we have to stitch separately. You release this synechiae, you stretch, and in this case, we're going to do a lens extraction after a capsulorhexis. So again, the Malyugin ring, as we've seen, comes to use, and you always use vision blue, even if you're doing open sky, and keep the pressure low to prevent further damage to the iris. And then the repair process, you can decide whether you want to do it at the time of the operation when the damage happens or subsequently. If you do it intraoperatively, the patient doesn't need a second operation and doesn't need the unhappiness or the dissatisfaction of coming out of the operation and saying, I've got a problem, it needs to be fixed again. If you've done it all together at the same time, at least you told them there was a problem which has been fixed. And the sutures are very, very useful, as we've seen again in damaging iris repair. And it depends on where the iris is damaged, the potential effect on the vision, and how you will suture them back into place. And there are different ways in which you can suture the iris. And you can do the same thing post-operatively, either repair the iris or counter the effects of the iris pigmentation by doing other things. As we see over here, you release the vitreous and you suture it in place, or you use these prosthetic devices, and there are a variety of these devices. Unfortunately, they've stopped making these kinds of aniridia lenses, but you can use this human optics aniridia lens, insert it, and to then address the damage. Like here, there's total loss of iris, so clearly there is no iris to repair, and you have to use one of these prosthetic devices, which come in different colors, and here a brown one has been inserted in this eye, and that was the human optics lens. So that's the summary, or the points have already been made in these eloquent presentations by the speakers on cataract surgery, and one has to prevent it by making sure you're working with a dilated pupil preoperatively, and if it happens, damage it, repair it during or after the operation. Thank you.
Thank you so much, Dr. Harminder. That was a wonderful presentation. Just a small question, like for the audience. When you have a patient who's under treatment for herpetic keratitis and eventually he comes for cataract surgery, what will be your standard protocol with regards to his medications?
So if the patient has been quiescent for a long time, then you give 400 milligrams twice a day of acyclovir, and you start that at least 1 or 2 weeks before the operation and carry it on for a long time till all inflammation has settled. for two reasons. One is that your stress of the operation can trigger the virus activation, and secondly, because you're going to use steroids in these patients post-operatively, you increase the chance of any reactivation to become florid infection. So to counter the effect of your steroid use, you will probably you will be helped if you use oral
That long time could be for a month or more?
Yeah, so if the patient is already on acyclovir prophylaxis, so somebody who's got repeated episodes of herpetic eye disease, we put them on at least for 1.5 years, 400 milligrams twice a day of antiviral, acyclovir that is. And then during that you can do the operation anytime. But if you're, and then the steroids use will be covered.
Thank you. Audience, if you have any questions related to the topics that were discussed today, you're most welcome to ask. Otherwise, you have been a wonderful audience. I thank all our friends and panelists, the co-instructors, for conducting such a wonderful instruction course. Yes, please go ahead, sir.
Sir, I have a question. Sir, if you don't know that is a viral disease in the cornea, suppose you don't know and you operate for the cataract and post-op there is an epithelial disease, how to manage it?
What you can do, you start topical acyclovir or ganciclovir 5 times a day, just like you would manage a patient who has not had cataract. You will do the same. But the question here is, what do you do with the steroids?
Yes.
So what one could do is not use steroids, but switch to something like cyclosporin drops, where they are more specific, they're not as much risk of activating the virus or keeping the virus going than steroids would be. So you can use acyclovir, you can use Icurvis that we have, cyclosporin. Here you have Sequa as well, so from Sun Pharma. So cyclosporin drops, or if you have tacrolimus drops, you can use that as well, and it will be less risky for the virus activation compared to steroids.
Sir, can we use oral steroids?
You can use oral steroids, but oral steroids will also increase the risk to some extent, not as much as topical. Yeah.
Excuse me, Dr. Haldipurkar.
Yeah.
Can you tell me the advantage of bevel down phaco tip?
Bevel down, oh yeah. Well, bevel down easily kind of cuts down on the phaco energy directed upwards. Okay. Now, if I have a patient whose endothelium not very healthy, my attempt would be to do more of bevel down phaco. Now, the only problem with bevel down phaco is you are closer to the posterior capsule. But then with your newer parameters, with bevel down, you can still stay away from the away from the posterior capsule and be more effective as well. So my practice is bevel down or bevel sideways, because that way your efficiency to purchase on the nucleus becomes higher.
So in all cases you go bevel down or only hard cataracts?
In most of the cases, some steps I would go bevel. In hard cataract like the one that you saw, when you go bevel down, you get a much better purchase quickly.
Thank you.
Notice sometimes at the bubbles, every time you try to get their chop, there are bubbles coming up. So I think that kind of reduces if you make the bevel slightly oblique, not maybe directly pull the bevel down, but that oblique definitely helps.
Thank you.
Thank you. Thank you so much. Can we have a picture with